This presentation is an introduction to critical care. In this presentation, we'll introduce what the critical care environment might be like, as well as pain and titratable intravenous infusions. The learning objectives for this module include: describe the intensive care unit setting and specific related nursing roles, introduce concepts of titratable intravenous infusions, and analyze appropriate considerations related to pain in the critically ill patient. Working as a nurse in the adult critical care setting requires specialized knowledge and skills. Critical care nursing involves nursing care of human responses to life-threatening problems, such as trauma, major surgery, or complications of illness, and nurses are typically in patients' rooms hourly, if not more frequently, depending on the status of the patient. These patients are often unstable, connected to continuous monitors, and have invasive lines that require informed care and interventions. Many ICU patients are sedated as well, so this introduces a number of additional considerations related to assessment and potential risks. How do we assess a patient's pain if they can't speak? What potential complications could arise from being unconscious for extended periods of time? And depending on additional therapies, such as mechanical ventilation, what additional risks are now being introduced and what further nursing considerations are involved? Patients in the ICU face many of the challenges that all hospitalized patients could face, but there are additional considerations for nurses to take into account when caring for a patient in the ICU setting. Because of the fast-paced, intense, and often noisy environment of the ICU, nurses must be attuned to common issues that could impact patient well-being and outcomes. Some of these major issues include anxiety, communication, and sleep. Anxiety is a very common issue for ICU patients and can occur for a number of reasons, such as loss of control, fear about threat to health or life, being in a foreign environment, memory loss, uncomfortable equipment and/or devices, excessive noise and light, intense pace of the ICU, pain, impaired communication, lack of quality sleep, and immobilization. To help reduce anxiety, it's important to teach patients and caregivers to express concerns, ask questions, and state their needs. Be sure to include the patient and caregiver in all conversations as you're able, and explain the purpose of equipment and procedures. Nurses can also structure the patient's environment in a way that decreases anxiety. For example, family or caregivers can be encouraged to bring in photographs and personal items as appropriate. Appropriate use of relaxation techniques such as guided imagery or music therapy may reduce the stress response that can be triggered by anxiety. Some patients may have anxiolytics or sedative medications ordered, which can reduce anxiety, but keep in mind that use of these drugs can increase risk for delirium. Communication is another key issue that ICU patients may face, especially those with artificial airways, sedative or neuromuscular blocking medications, or conditions that inhibit ability to communicate. Throughout your nursing care, be sure to explain what will happen or is happening to the patient, even if the patient is not responsive. Patients who are intubated will not be able to talk. However, many of them may have periods of wakefulness where they try to communicate with the nurse. And this can be very frustrating for patients and requires a patient nurse who can anticipate patient needs or concerns. Asking an alert but nonverbal patient yes/no questions and attempting to anticipate potential concerns can meet some communication gaps. Using additional methods of communication, such as a picture board or notepad, can also be helpful. When speaking with the patient, you may need to stand closer to them and speak more slowly or loudly. If family is present at the bedside, you can also encourage them to support communication efforts and continue to speak with the patient, even if the patient does not respond. Sleep is another concern for ICU patients and can increase a patient's risk for delirium. This is often due to noise, anxiety, pain, invasive devices, and frequent assessments. To promote sleep, the nurse can incorporate a number of interventions as appropriate for the patient's condition. Scheduling resting periods throughout the shift as feasible, dim or turn off the lights at night, open curtains in the patient's room during the daytime, providing eye masks and/or earplugs, limit noise, and gathering assessment data without disturbing the patient when possible. While management of anxiety and promoting communication and sleep appear to be simple, compassionate nursing considerations, each of these has direct physiological implications. Stress, anxiety, and lack of sleep can increase risk for delirium and place your patient at risk for complications, delayed healing, and prolonged length of stay. These are compassionate nursing interventions, but also can impact the physiological health of your patient. While a basic nursing skill is thorough pain assessment, assessing pain in a nonverbal patient in the ICU poses new challenges. It's important to note that not all ICU patients are nonverbal. So when we're able, the patient's verbal report is still considered the gold standard for patient assessment. All ICU patients are at high risk for pain, but especially those who are immobilized, have invasive devices, and specific illnesses. Inadequate pain control is not only an issue of patient comfort, potentially causing anxiety or agitation, but it can also increase the patient's risk for delirium and even delay healing. Keep in mind that even a patient who is sedated or unresponsive can still experience pain. Once we are caring for a nonverbal patient in the ICU, assessing pain can be more complex. To carry out this pain assessment, we need to consider nonverbal signs of pain that are often displayed by activation of the sympathetic nervous system. Pain can cause tachycardia, hypertension, and diaphoresis, as well as guarding, muscle rigidity, and grimacing. It's important to do a thorough pain assessment in a nonverbal patient because some signs of pain, such as tachycardia and hypertension, may be signs of other conditions. For this reason, ICU nurses use standardized pain scales. While each facility may adopt different pain scales, two common examples are the Critical Care Pain Observation Tool, or CPOT, and the Behavior Pain Scale. Here we can see two examples of pain assessment tools appropriate for the ICU. You'll notice that both have some similarities, where it's important to assess the patient's facial expression, body movements, and compliance with the mechanical ventilator. This last component, compliance with the mechanical ventilator, refers to how the patient is interacting with and tolerating mechanical ventilation. Are they fighting the ventilator in a sense and causing it to alarm frequently? Or is mechanical ventilation well tolerated and fluid? With the CPOT, the nurse also evaluates muscle tension in response to passive movements. Keep in mind, to correctly use the CPOT, it's important to perform these passive movements after assessing other components of the tool. With these pain assessments, there's a few important things to consider. The total score a patient receives as a result of using these tools is not intended to estimate what the patient would have stated verbally if they were able. For example, we aren't assuming that a patient scoring a 7 on the CPOT would have scored their pain at a 7 if they could have expressed their pain level to us. Another key consideration is that pain assessments should be completed per facility protocol and as indicated. Just like we would reassess pain in a verbal patient after administering analgesia, we need to reassess pain using a tool like the BPS or the CPOT and document after administering analgesia or titrating continuous analgesic drips. While many ICU patients require intensive analgesic medications such as opioids, do not forget the fundamental importance of thorough assessment. A nonverbal patient experiencing pain may be uncomfortable due to poor positioning in bed or laying on devices. Assessment of some of these reversible causes is critical to reducing risk for complications related to the cause of the pain, and this also includes identifying when analgesic medications such as opioids may not be the best option. Additionally, a number of non-pharmacological therapies can provide significant and meaningful pain control for ICU patients. When appropriate and available, therapies such as music therapy, massage, aromatherapy, meditation, repositioning, and distraction, these can be helpful and effective options for patients, either in addition to medications or on their own. Let's test your knowledge. Which of the following is a likely sign of pain in a patient who cannot verbally communicate with you? Select all that apply. Eyes clenched shut when turning the patient. Decreased respiratory rate. Patient resists bending of her elbow when you try to contract her arm. Axillary temperature of 36.8 degrees Celsius. Heart rate of 120 beats per minute in a 54-year-old male. Mechanical ventilator compliance. The correct answers are eyes clenched shut when turning the patient, patient resisting bending of her elbow when you try to contract her arm, and a heart rate of 120 beats per minute in a 54-year-old male. Note that these correct answers are easily identifiable in these nonverbal pain assessment tools as well. Also, even if we identified these findings in a patient, further assessment is always indicated. A patient with tachycardia, for example, may just be anxious, but not in pain. Also, a patient clenching her eyes when turning her may be laying on equipment or devices that have been left underneath her and just need to be removed. Another important skill that ICU nurses must have is management of titratable intravenous infusions. So units outside the ICU may include care of patients with continuous infusions that require monitoring. But what's new to the ICU environment is continuous infusions that require frequent assessment and titration. This means that it is within the nurse's scope of practice to increase and decrease a continuously infusing drug according to a patient's response. These increases and decreases in rate do not require a call to the doctor because the continuous infusion has been ordered in a way for the nurse to use their clinical judgment and the ordered protocol to adjust the drip rate. So in the ICU, patients may receive continuous infusions for the purpose of providing analgesia, sedation, neuromuscular blockade, arterial blood pressure management, and many others. But most commonly, you'll see continuous sedation, analgesia, and vasopressor drips. Now, each of these continuous infusions requires close monitoring by the nurse. For example, if a patient with continuous analgesic infusion has signs of increased pain, the nurse may need to increase the infusion rate. If a patient is receiving continuous sedation infusion and begins to show signs of agitation that are now negatively impacting care, the nurse can increase the rate of the sedation medication. This continuous titration can be a new and uncomfortable concept, but there are important considerations to review. As with any other medication, continuous infusions must be ordered by a provider, and those orders are quite detailed. So as you would expect, the name and the row of the drug must be provided. But we also need a starting infusion rate as well. And we also need a protocol for how frequently the drip rate can increase and decrease and by how much. A max infusion rate must also be included so we know when the drip can no longer be increased. And another important concept of the provider orders is parameters, or an objective clinical endpoint. Why is the patient receiving this drip? We need to have a goal for this infusion therapy. For example, what is the target pain score? Or what is the goal sedation level? What is the goal mean arterial pressure? We need these guidelines in order to appropriately titrate continuous infusions. When caring for a patient with continuous titratable infusions, there's a number of important nursing considerations. Because these are infusions, they are counted toward the patient's intake and should be documented in the health record. Also, whether or not you are starting the infusion or you're assuming care of a patient who's already receiving a continuous infusion, you will need to do some key checks when you begin your care. First, ensure that the drug is being infused via guardrails so that the pump is programmed appropriately. Also, when you're checking the pump settings, verify that the concentration of the IV bag matches the concentration programmed into the pump and calculate the infusion rate, making sure that this matches the pump rate as well. Additionally, when verifying rates of infusion, ensure that these fall within the prescriber orders. None of the rates should be above the max rate, and if so, that warrants a call to the provider. When caring for patients receiving these continuous titratable infusions, it can be intimidating when there's more than one, or many more than one, continuous infusions to manage. It can be a lot of work to manage multiple titratable infusions, but as you can imagine, it's very important. As a nurse working in the ICU, you must ensure that you do not run out of a medication, especially those that may require a request to the pharmacy and may not be readily available on the unit. Keeping track of which infusions can be run into which peripheral or central lines and which can be run together takes a lot of focus and preparation. To keep track of these infusions, it can be helpful to use tape to label IV pumps as well as the IV tubing itself. Keep in mind that your patient may be receiving multiple infusions targeting the same purpose. For example, a patient with hypotension may be receiving multiple titratable vasopressors. In this case, the nurse needs to consider which medication should be titrated up first, and as the patient improves, which medications should be titrated down or even off first. It can be helpful to have these discussions with the healthcare team and consider potential side effects of certain medications when determining which drips to titrate. In the case that a drip is titrated off, it's important to keep the healthcare team informed. On the other end of the spectrum, you may find that you have hit the maximum infusion rate for a continuous infusion. In that case, it's also important to inform the provider. This might mean that the patient needs an additional infusion with the same goal. It also might mean that the provider will increase the max allowable rate. Or it may mean that the medication for that intended purpose needs to be changed altogether. Continuous infusions may also need to be changed if the patient is demonstrating adverse effects from that medication as well. In this case, the nurse will often inform the healthcare team that the patient is not tolerating a certain continuous infusion and make a recommendation for an alternative medication or request that an alternative medication be ordered. Here you can see an example of an order for a continuous infusion with the goal of managing pain. It's important to mention here that these protocols and order sets will vary facility to facility. The purpose of showing this example order set is not to memorize it, but to understand some of the basic components to look for. You'll notice that this order is for continuous fentanyl. The provider is prompted to provide that key parameter or goal, that target pain score for the nurse to titrate to. The provider will also indicate the starting infusion rate, indications for boluses, and indications for titrating the drip, as well as maximum doses. Let's assess your knowledge. You walk into your intubated patient's room with an IV fentanyl drip at 25 micrograms per hour, who presents with the following: heart rate of 130, blood pressure 140/90, respiratory rate of 29. Which of the following should the nurse do first? 1. Ask the patient to describe her pain. 2. Increase the fentanyl drip rate per protocol. 3. Call the physician for additional pain medication orders. 4. Get a music therapy consult. Or 5. Look at the patient's facial expression and muscle tension. The correct answer is 5. Look at the patient's facial expression and muscle tension. Remember, tachycardia, tachypnea, and hypertension can be signs of a problem other than pain. We need to further assess the patient. Also, asking the patient to describe her pain while she is intubated will be very frustrating for a patient who cannot speak. There is also no need to call the physician for additional orders because we do already have a titratable continuous infusion to treat pain, if that is the problem. Getting a music therapy consult may be helpful, but again, we need to first assess the patient further. If, with further assessment, the nurse determines that the patient is in fact demonstrating signs of pain, he or she could refer to the continuous infusion orders and increase the drip rate as indicated.